So I would like to take this week class as in we're going through I would say I'm not saying theory, but let's understand the concept first. And next week where we're going to having discussions about I think challenges in surveillance in developing countries. That's where we can have a look in more details of specific countries, particularly I would say in Southeast Asia. Okay, so first thing first, I think this is where everyone's know, or I would say like by now they should know, is that NCD is a global burden and it's account for 68% of global deaths. And these NCDs impact low middle income countries more than high income countries. And in low middle income countries, cumulative economic losses from NCDs are projected to exceed 7 trillion between 2011 and 2025. So we can see here, NCD is not just affecting health or mortality, it's also affecting the economy of the countries. Okay. So in the information of age, data is essential for decision making at local, national, and global levels. So let's start with definitions. Surveillance is defined as the ongoing collection of data for a specific public health purpose, such as monitoring a local population or targeting interventions, while data sharing is focused on the secondary use of that data. So by making surveillance data available to academic researchers and international agencies, it values its maximized for the global good through transparency, and cost efficiency. However, hold on, let me just minimize this. Can I minimize this?
Yeah.
Okay. So, however, despite global commitments, there is a lack of systematic frameworks and operational guidelines limits the value of this information. So for this, I would say discussion for today, I'm going to focus more about data sharing. But bear in mind, data sharing and surveillance is not totally two different things. You need to have surveillance in order to share your data, or you need to share your data in order to have surveillance system. So for today's class, we're going to have a bit more discussion about data sharing. Okay. So I think there are 6 barriers that have been identified in data sharing. The first one is technical challenges. So data sharing cannot be a priority if basic collection systems are not functional. And these are the 3 issues identified in technical challenges. First is data not preserved or archived for the long term. Usually, it's like maybe 7 to 10 years, depends on the healthcare system. And language barriers in an international context. And I would say for Malaysian, we are still using Bahasa Malaysia when we are taking information from the patients. So these language barriers for international context is a bit tricky where they need to translate, and sometimes there's a few information missing in the translation. And lastly is the restrictive formats such as hard copy, paper, or antiquated electronic files. And when I was a medical social worker, I think last 4 or 5 years, yes, we still use hard copy paper. So all our reports are still using papers, and we still have this one huge storage contains all the reports. And I was like, how can we track back if we have this lot of hard copy paper? So that's like, I think we are slowly moving forward to more advanced electronic files, but I think we still have a lot of things to do. So for example, between 1950 and 2010, up to 20% of deaths in certain countries were attributed to ill-defined codes, making the data nearly useless for specific policy planning. Again, I think this is also very important when you collecting data. And certain people, I think this is where a code book is needed when you're collecting data, and it needs to be utilized for everyone's in healthcare system or even in researcher. So this is where the transparency comes in. So because sometimes different people or different department assign different codes for similar things. And that's where the codes jumble up and we couldn't use the data, especially for the policy planning. And these challenges highlight that technical capacity is a prerequisite, but not sufficient for effective surveillance. So we need to do something about the technical thing first. So the second barrier, so this is about the scandal of invisibility. So high-income countries are 16 times more likely to have usable NCD mortality data than LMICs. And millions of people in the developing world are born and die without being recorded in any formal system. And without accurate baseline data, countries cannot measure progress against global health targets. So I think this is where my field comes in a bit more. So I am in gender studies program. So we're looking at, and I'm looking at public health from gender lens. So may I know here, anyone knows what is gender lens? So how can we look at public health or healthcare system from gender lens? Anyone wants to try?
Anyone want to answer the Dr. Nadira question?
Just try. I mean, like,
Right.
there's no right or wrong answer.
Perhaps you can repeat the question, Dr. Nadira.
Okay, so my question is, I'm from gender studies program. So I am a public health specialist looking from gender lens. So my question is, what do you think if we are looking at, for example, surveillance or data collection from gender lens?
Yeah. Okay. Most of you students already have a background working, right? Pak Karis mungkin mau coba, Pak Karis ada nggak? Try to translate if I think Nadira also can speak bahasa.
Okay, bahasa. Okay. So okay.
Okay.
Soalan
Just
saya.
translation.
Okay,
Yeah.
sure. So soalan saya public health kesihatan awam specialist. Tapi saya melihat healthcare system or surveillance dalam untuk kelas hari ini surveillance from gender lens, gender. So boleh sesiapa teka macam mana ataupun bagaimana saya melihat sistem or surveillance tu daripada lensa gender.
Ya. Ada yang mau jawab? Jadi mungkin Pak Yohakim atau yang sudah bekerja nih sebagai petugas puskesmas atau dinas atau mana kira-kira atau yang saat ini sedang Anda lakukan nih di tugas lapangan surveillance atau screening, ada aspek ketika data collection ada aspek gender apa yang ada di situ. Ya, ini tampaknya malu-malu semua ini. Ateja, Bu Elizabeth. Semuanya wake up aja ya, bangun kan? Saya jadi khawatir ini. Bu Iye, wanna try?
Ataupun soalan tu terlalu susah.
Contoh deh yang surveillance tuberkulosis deh, yang di puskesmas. Ada aspek gender apa yang masuk gitu. Oh, ini bisa ulangi berapa Bu Ye. Bu Ye di sistem surveillance ini kira-kira kalau dari kacamata gender gitu ya, data collection atau ada apalah isu atau tema terkait gender nggak di yang sudah pernah Ibu lakukan di Bu Ye di puskesmas ya kelihatannya ya kalau nggak salah ya, di primary healthcare ya
Ya,
Bu Ye.
ataupun kalau sesiapa yang terlibat dengan develop polisi, merancang polisi
Iya.
atau program. So, apa yang Anda lihat melalui lensa gender?
Oh, nggak bisa unmute. Oke, boleh deh ditulis di chat Bu Ye.
Boleh.
Kira-kira.
Mohon
Oh ya,
ditunggu.
oh ya, boleh. Pak Yo Hakim, ini semuanya udah bangun nggak sih Pak ya?
Sudah, Mak. Sudah, Ibu. Ini sudah, Pak. Saya bisa settingan unmute, Ibu.
Oke.
Kan, Ibu?
Oh ya, Bu Ye, katanya settingnya udah dibuka nih, bisa unmute sekarang Bu Ye.
Sudah, Ibu.
Oke, silakan.
Iya Bu, terima kasih. Gak apa-apa pakai bahasa Indonesia ya Bu.
Boleh.
Boleh,
Saya masih
boleh.
belum masih blank kalau pakai bahasa Inggris. Ya terima kasih Bu. Saya kebetulan di Dinas Kesehatan Kabupaten. Kalau terkait gender, biasanya kebanyakan kalau misalnya kayak TB, kebanyakan di laki-laki atau di sama kusta juga kita kebanyakan kasus tuh di laki-laki gitu. Paling itu aja Bu.
Okay.
Yeah.
So, yeah. I would say kebanyakan negara di Southeast Asia ataupun South Asia, kita masih melihat ataupun kita masih mengumpul data dari sudut seks jantina, sama ada lelaki atau perempuan. Itu saja. Tapi daripada saya lensa gender, kita tengok more than that. We look beyond that. For example, stateless people. So regardless of the sex, whether female or male, sometimes stateless people, they are not being captured in the healthcare system. So for another example, I think much more easier is to understand is a migrant or refugee, because they don't have like solid documentation, right? So they cannot access healthcare easily compared to the citizens. So that we are missing these numbers. For example, like if correct me if I'm wrong, because TB is a contagious disease, right? So if we're not capturing people, like, for example, refugee who has TB, then we are not sure how many actually people from refugee population that has TB. And they are not being included in any policy or programs after that. So that's where I look at. So I look at more than that. For example, if even for the citizens, sometimes we also need to look at the socioeconomic. For example, household income, and if let's say power imbalance. For example, if a wife comes in or she's not feeling well, but her husband are not allowing her to go to the healthcare to treat herself, that's where we also lack of data because of the power imbalance that happen outside the system. So this is where I think it suits with the second point, where millions of people in developing world are born and die without being recorded in any formal systems. Sometimes like migrants or like refugees or stateless people, they don't even have in the formal system. Is that clear? Is that clear so far?
Yeah, it's clear.
Is it clear so far? Okay.
Okay, so let's talk a bit more about gender. Gender as a core equity stratifier. I would say gender is a very important element in everything because even in SDGs, Sustainable Development Goals, gender equality is we have a specific goals for that, which is SDG 5. So gender is identified as one of the 4 essential equity stratifiers. Alongside with a socioeconomic position, ethnicity, and geographical area to measure health equity. And why this is matter in the surveillance context is because surveillance data is often not linked to power dynamics, which prevents health officials from assessing health disparities. And to move toward 21st century population health, system must collect gender disaggregated data to ensure resources reach the most vulnerable groups. And I think Lintang, Dr. Lintang, I think this is also my suggestion or for everyone's, for each of you is to look at gender mainstreaming when you're doing health policy or health programs. So gender mainstreaming is where we move beyond, there's no one policy fit everyone. So we need to have a targeted policy or programs for each groups. So that's my element here in surveillance of healthcare system. So the second barrier is motivational factors. So data sharing requires resources that are often diverted from other pressuring duties. And this is, I can say that in Malaysia, we, the pressing duties or pressing issues depends on the government. So, and the data, again, is, we need, I think the most important things in data sharing or even data collection is financial. So, and sometimes, especially in certain areas, if it is not too pressing from the government lens, they wouldn't really invest in doing data sharing or data collecting. And second is providers worry that secondary analysis might reveal errors in their work or continued disease occurrence despite their efforts. So this is where I would say accountability. So sometimes people afraid to share their data because of this. So again, as a researcher or as someone who collect patients' data or work with any data, you need to be transparent, you need to be ethical, and also I think most important thing here is the transparency. If let's say you make an error in that, I think every human being makes mistakes. So just own it and then try to find a solution for that. So for example, here studies have shown over-reporting of vaccine coverage by national statistic compared to independent surveys after the introduction of performance-based funding. So this reflects how institutional incentive can discourage transparency and collaboration. So the opportunity cost of sharing. Public health officers fear losing scientific credits to outside researchers with better analytical tools. And data producers may feel exploited if they receive no credit or benefit while secondary users advance their careers using the shared data. And this is a particularly severe barriers in low resource settings where local researchers struggle for recognition. And I think this is a very valid point because at one point you want to share your data, but also at the same time you were like, what if someone used my data and they can advance their career, but I'm still here? But again, I would say in a healthcare setting or in a public health, we should not keep data that we have, but we need to protect the data that we have. So this is where you need to make sure your IP, your patent needs to be I think I would say legalize before you share the data. So you need to know all the legal things, which is, I think that's another thing that you need to consider before you're sharing the data, or you conducting this or you making the surveillance system. So the third barriers is economic obstacles. Data sharing requires human and technical resources for annotation, communication, and connectivity. Reporting an outbreak can trigger overreactive market forces, leading to massive losses in tourism and trade. And for example, the global SARS outbreak caused estimated losses of approximately 50 billion, where foot and mouth disease in the UK cost approximately 30 billion. So again, if you are having surveillance system and people know about that, it may also affecting your economic systems or economic of the country. And this shows that economic consequences can discourage timely and transparent reporting. So the next barrier is political. A fundamental lack of trust between providers and users can lead to fears of data misuse or intentional abuse. Official rules for sharing are often non-existent or inconsistent, leading to protective policies that default to secrecy. So for example, in 2007, the Indonesian government refused to share H5N1 samples with international community due to the concern that the samples would be used for financial gain by others without local benefit. So I'm going to throw this back to you. Is this happening? I mean, was this happening? Because during that time, I'm still, I think, standard 1. No. I was 13, yeah.
Ayo, Pak Karis mau coba jawab? Ya tembak langsung. Mr. Karis, go ahead, please.
Boleh diulang pertanyaannya, Bu?
Okay.
Okay.
Soalan saya, kalau kita tengok example di sini, in 2007, the Indonesian government refused to share H5N1 samples. So my question, was it true? And was it true because the concern of not sharing is because they afraid that the sample would be used for financial gain by others without local benefit?
Dulu pas zaman flu burung, Pak Karis sudah bekerja kan? Ya.
Sudah.
Ini Dr. Aran, he's a vet.
Yeah.
So yeah, I think the question is appropriate for him. Okay, let's go.
Yes.
Oke, Assalamualaikum warahmatullahi wabarakatuh. Good morning, Dr. Nadira. Selamat pagi, Bu Lintang. Saya nak cuba jawab soalan sikit lah.
Yes.
About in 27, we have a case of avian influenza. Pertanyaan tadi untuk ini ya, apa namanya? Apakah ini mempengaruhi?
Enggak. Jadi pertanyaannya Pak Haris, benar nggak isu itu bahwa kita pernah nggak mau kirim sampel ke WHO lah. Kalau dari Kementerian Kesehatan biasanya kan kirim ke BSL lab yang BSL 3 ya kalau nggak salah ya. Itu yang harus keluar tuh loh, yang WHO CRO itu. Nah, itu benar nggak isunya? Terus karena takut, kalaupun benar, apakah benar karena takut nanti sampelnya disalahgunakan?
Okay. I try not answer a bit political answer.
Yeah.
So in the 27 we had a case of avian influenza that why samples didn't send to international. Sometimes our government have a late response actually about the cases of disease, but as my opinion, every single pandemic or maybe every single pandemic that happen in Indonesia, sometimes they think about the financial financial factor before they think about the safety of the patient, safety of the community before. Why? That's why as we know in COVID, Indonesia is lately do like a lockdown system. They apply lockdown system lately because they think about when we do lockdown at the first time, it seems like a case of H5N1 or avian influenza. If we send the sample first, and know about the causes or something, it might be evac to poultry, evac to another companies. That why yang bergantung, yang apa bergantung itu apa bahasa Inggris? Yang he depend with the poultry factor. Itu it might be effect local financial then, and as we know, as supply and demand rules, when this issue rise, it might be price of the chicken, price of the everything about the poultry that associate with the avian influenza. It might be a rise and make a chaotic in the situation economic. So that's why it's not about why they didn't send the samples, because it might be disalahgunakan.
Misuse.
Misuse, but I think it's more because our citizen can accept it about the case of it, the situation that appear came from the poultry factory. For my answer is itu. Dan soalnya kan mohon maaf pakai bahasa sedikit. Soalnya pada saat 2007 ini saya nak join elimination about the poultry. So many farmers have rejection because if we found some cases in the poultry, in the farm, we check one chicken, and this might be suspect avian influenza. The government police is when we find one, we burn everything. That's why some rejection, some is impact to local financial actually.
No,
thank you, Doctor.
Thank you so much. I mean, that's a valid response, I think. Like we just discussed about economic barriers, right? So sometimes when we're sharing about this, one is tourism, but with this example, H5N1 influenza is affecting the poultry. So sometimes it's also affecting the trades. And also, I think another thing is also about panicking. So the government try to contain citizens or like international people to not panic. So again, that's a valid reason, but I think we need to consider political barriers too when it comes to surveillance or data sharing. So I would say all those barriers that I'm going to discuss with you, all of you, are not working in siloed. They are connecting with each other. So for example, political barrier, it connecting to economic. So that's why I would say these barriers are a bit tricky to have a solution, just one solution. So we need to have, I would say like more solutions, because we need to tackle every barriers in surveillance or data sharing. Thank you so much for sharing that with me. And I think the last barriers is legal and ethical issues. So it is often unclear who owns public health data, leading to ad hoc restrictive guidelines. And strict laws such as HIPAA in the United States can make agencies hesitant to share even anonymous data. And for example here, a project in Canada, integrate national and provincial survey data was stalled because each province required a different approval. And lastly, this balancing data access and protection remains a central challenge in public health governance. So, besides the political, even where we can do surveillance or sharing public health data, there's a legal and ethical issues here. And again, we also need to discuss about the bureaucracy. There's a lot of stage or approval process that we need to go through before we are able to publish or to do the surveillance system. So that's the barriers, like as in the major challenges. So now let's looking at the operational. So first thing is the denominator problems. So to calculate disease prevalence, we need to know the total population served by a health facility. However, in many regions, there is no formal registration of citizens to specific providers, making it impossible to determine an accurate denominator. So for example here, in the Swiss Sentinel Surveillance Network, researchers face challenges because while they recorded gender of asthma patients, they did not always record the gender of every person who visited the clinic. So without knowing the gender breakdown of the total population at risk, it is impossible to calculate accurate morbidity rates. So again, this goes back to from the first stage of having surveillance or data sharing, or even to create surveillance system, is of how you collect your data. What are the informations that you need from your patients or from your populations in order to have an accurate any prevalence rate? So that's the operational challenge. So next is the private sector gap. So in many LMICs, the private sector is a primary source of care, but remains largely unregulated. In India, 69% of the urban population prefers private facilities, yet these providers are rarely integrated into national surveillance system. So as a result, national data sets often miss the majority of the population who bypass the public health system. So now I would like to know, is this happening in Indonesia? Because I would say this is also happening in Malaysia, as we have a lot of private clinics, private hospital. So may I know what you think about Indonesia? Are we the same?
Ayo,
Yeah.
ada yang mau jawab? Gimana kondisi Indonesia? Apakah sama dengan Malaysia, di mana swasta ya atau private yang tidak?
I want to
Oh.
talk in the context of my country.
Yeah,
Okay, first Deng. Deng is one of our international student, Dr. Nadira.
Oh, hi. Okay.
Okay.
Go on, Deng.
To talk specifically for the context of my country, South Sudan, it is obvious that private sectors are prepared more than government institutions, because in government institutions, patient wait for a long time, and patient would not tolerate that they should be waiting in the line. They prepared private institutions that do their work faster and they receive patient also. Therefore, as some of the vital things that should be integrated in surveillance systems are always missed. And when the government tried to look into that, there is no clear solution on how to to solve those particular issues, those one always remain as gap in the surveillance system.
That's true. That's true. So I think I would say same as Malaysia, we still I'm not saying fighting, but we still are not meeting in the middle between private and public. So if just to share with you, Malaysia Healthcare Ministry of Health, we are doing a white paper on healthcare system in Malaysia. So again, I'm not sure where we at the moment about white paper, but in that white paper, we are trying to bring both private and public sector on how we can have I would say equal healthcare system at the moment, because at the moment we are not really know anything much about private sector. So thank you, Dan, for sharing that with us. Anyone wants to add from other country or for
Yuk, yang dari Indonesia belum nih, yuk. Sama
Ya.
Indonesia.
Izin Bu ikut
Ya,
menambahkan.
boleh.
Heeh.
Lah.
Ya, terima kasih Dr. Nadira. Izin saya dari Kabupaten Majalengka, cuma yang saya tangkap adalah Indonesia memang masih memiliki gap antara pelayanan di swasta dan di pemerintah. Cuma makin ke sini kita berusaha menghilangkan gap tersebut dengan memasukkan pelayanan di swasta ke dalam sistem pencatatan dan pelaporan penyakit di Indonesia gitu. Seperti di HIV ada yang namanya PPCP, jadi public private, istilahnya pelayanan di swasta yang include masuk ke sistem pencatatan dan pelaporan di SIHA 2.1. Sama juga dengan TB, kita mulai mendaftarkan pelayanan-pelayanan di sektor swasta ke dalam sistem pencatatan pelaporan TB di SITB. Begitu juga dengan penyakit lainnya, kita di pelayanan di seksi pelayanan rujukan kalau nggak salah, kita berusaha mendaftarkan, memasukkan semua vaskes swasta yang terdaftar di kabupaten kota dan terutama di kabupaten saya sendiri ke dalam sistem pencatatan dan pelaporan penyakit terpadu gitu.
Okay. So
itu contohnya.
Yeah. Thank you so much. So I would say Indonesia are doing a good job in trying to collect data from private sector. I think that's a very good, and I think that's how we should do moving forward. Is if we have so many sectors, we need to bring them together in order to have one strong national surveillance. Okay, so let's continue a bit more about understanding information inequity. So disadvantaged groups and migrants, like I mentioned just now, often have lower quality data because they have reduced access to formal health systems. And patients may underreport stigmatized behavior like smoking or alcohol use during surveys, and this will lead to policy to have like misallocated resources from those who are invisible to the system. And this reinforces the scandal of invisibility, where entire populations remain statistical unseen. So again, this is where my work comes in. My department and we are looking at which groups that have been invisible from the government or from the formal systems. So we are trying to say like, hello, you are missing this group of people. So we need to do something about this. And then for example, another one is patients may underreport stigmatized. Again, as we all know, sex worker is illegal in Malaysia. So some sex workers are also human. They also need healthcare. They need the they need to go to the healthcare to get the healthcare system. So sometimes they tend to not telling, or they tend to keep a few informations for them because they don't want to know, to let other people know that they are working as sex workers. So this will lead to, for example, any programs trying to minimize HIV, for example, or STD. So because we do not know how many of them are actually having that and what are the roots of that, which is from their works, but they are not telling that. So that's my work comes in, where we're looking at this invisibility. So how the system works or link. So barriers to data sharing that directly shape NCD surveillance outcomes. So if we have fragmented data, means that we're going to have incomplete disease monitoring. And if we have lack of standardization, we have poor comparability. And if we have political and economic constraints, we're going to have limited system integration. And this create a cycle: weak data sharing to weak surveillance to weak poor policy decisions. So I think that is why I decided to start my class, or to this week discussion with data sharing, because from data sharing, we're going to create surveillance. So without understanding the barriers in data sharing or the challenges in data sharing, we cannot really understand about the surveillance. And next week, we're going to do a bit more practical, where we're going to look at countries for the examples and try to understand the barriers there. Okay, so now do we still have time? Okay, we still have time. I'm going to throw this to you. So what I need you to do now is identify a real world report or data set on any NCDs. And I want you to identify 2 barriers to data sharing or surveillance based on what we have discussed just now. Identify 1 likely source of bias or data limitation and suggest 1 realistic improvement. And these are the questions that you can use to think identifying the answers. So first is, what data sources are used and what might be missing? Are there signs of fragmentation or lack of integration? And who might be excluded from this data? So now it's almost 5 minutes to 11. Is that okay if I give you like 15 minutes? So we come back at 11:50 and try to have I think for like 10 minutes discussion on what you have find. Is that okay?
Guys, dijawab guys. Is it okay? All of you understand what Dr. Nadira asking for you to do on 15 minutes?
Yeah.
Okay.
Paham ya?
Non-communicable-nya, Bu.
Nadira,
Penyakit tidak menular ya.
Yeah, can they do communicable?
Communicable? Yep,
Disease?
yep,
Infectious disease?
yep.
Okay.
Anything.
Ya, boleh Bu. Boleh penyakit penular, boleh penyakit tidak menular.
Yes.
Yang penting cari ya reportnya ya, kalau
Yeah.
ada dan sebagainya. Gitu. Okay. Any question first before I'm starting counting 15 minutes?
Yes, thank you.
Ini masing-masing.
Gimana? Gimana Bu Yi?
Masing-masing.
Concerning, okay.
What is that?
Okay, I am saying that as you have seen that there is one of the problem that we may miss some vital thing concerning what you have said about sex worker being illegal in the country.
Yeah.
And people might be suffering in relation to their work that they are doing.
Yep.
But they don't want to open up because it is already illegal or illegalized by the government. When that one has been detected, what is always proposed as solution by the stakeholders? Because stakeholders have seen that one, it is they have legalized it and people are still doing it. And because it is illegal, people will not be open because they fear that they might be accountable. and they are still doing it. They will not be open, and their health system deserve, and even those people, they are beneficial to the country. Their health is very important. Now, what do stakeholders propose as solution to such kind of difficulties or gaps?
Yeah. I will say for us Malaysia, this is one of funder from I think World Fund share with me. So they are providing vaccine to sex workers. But again, sex workers is illegal in Malaysia, and also they are not being documented. So there's like two illegal things that have in these sex workers, right? So this is where he shared, like the funders shared, it's very interesting to see how Ministry of Health in Malaysia have two sides. So one is a group that I would say like looking from the moral lens, say that we cannot do this, sex workers are legal. So if we are giving these vaccines, means that we are sort of like informally legalize them. But another group was like, but we're looking at the health here, because most of the clients are Malaysian. So if you're not giving these vaccines to them, means that we are also not protecting our own citizens. But the conclusion here are they still providing the vaccines to the sex workers without having their formal identity recorded. So means that they use like false names in order to record that. And again, that data is not publicly available. So that's like another thing that I would say Ministry of Health trying to do, but also at the same time, we don't have data about that. So Malaysia, I would say certain not disease, but certain certain disease, we are still gatekeeping that from public. Okay, so I hope I'm answering your questions then. And let's meet at 11:15 if that's okay.
Ya, ya Bu Ye, masing-masing ya Bu Ye ya.
Yeah.
Punya ide ya. Oke.
See
Ya, in
you.
15 minutes.
Okay. Okay. Can we start now?
Udah siap ya? Ready guys?
Okay.
Who's first?
Anyone wants to share?
Ayo, Bang Haris, coba deh.
Sudah kuduga.
Because you're the only one that opened your video. Okay,
Okay.
that's good.
I try to answer about the task. The first question is do various data sharing or surveillance. We have a health information system. So the obstacle is data. Data is often spreading across various platforms, like in TV surveillance in Indonesia, especially in Semarang. We have two platforms they call Semar Betul. It's especially for Kota Semarang, and for the Indonesian global is SITB. But they are not, sometimes they are not interconnected between community health center, regional hospital or private hospital, because when we collect the data, when we do field assignment by Dr. Lintang, we find some gap data from the SITB and Semar Betul also. I don't know, maybe it might be because the person inconsistent to reporting or something. We don't know. We still analyzing the root cause. And the second question is, the second barrier is a private sector participation gap. As we know, private facilities are not fully integrated with not all, but some private health facilities is not fully integrated into the national reporting system. So sometimes clinic like private clinics, hospital is not frequently reported unrecorded to our system. Or we didn't know actually in a health department, but I saw in a Puskesmas when we collect the data from the Puskesmas between two platforms, it's already have a gap. And also we already checked in the health department in the health department of Semarang. They had a similar gap in the one reported. So next for the question number 2, one likely bias and limitation that I found is selection bias. Like I said before, sometimes they found inconsistency for the reported and recorded the data for the data collection. It might be make a selection bias, like I already discussed with Dr. Lintang. There is some data from the screening of the hypertension that we already conduct in the Puskesmas. The officer 1 creates the data completely, and the officer 2 creates data and incompletely. So it's very make possibility of selection bias. And then next to the question number 3, suggestion one realistic. Actually, we in Indonesia we already have a platform. The name is Satu Sehat, but for the implementation is didn't optimum yet. I ever seen in Malaysia, like I don't know, it might be possible in Indonesia or not, but in Malaysia I ever see they use MyCard, like in Indonesia they use iKTP. They use MyCard. It's only one tap and then the data is already integrated. That when I showed the technology about the MyCard, between MyCard and iKTP, it's similar. They use biometric system. They use big data countries. They use big data countries. But I don't know why Indonesia make data from the iKTP, from the SITB, and another platform is different. But in Malaysia, I show in my card when I buy some gas in the gas station, when already tap the card, I already which one petroleum that I will get its type is already connected in one global country big data. It's already that's why if we can do in Indonesia, it might be potential misusing data, or maybe for the ethical and the data will be interconnected every single department that we show before. So so the guiding question is what the data source are used and what might be missing. It's I think, from my opinion, it might be missing from the people who work in the public health facilities, because sometimes they have workload so much, they sometimes inconsistency about the time, about the maybe forgot something. And then when we talk about the site of fragmentation, yes, of course, in district level, data not immediately synchronized with the central system. That's why I say in Puskesmas and the health department, they have one cases gap in the I get in 2026 when I see in the Semar Betul and SITP is 5 cases, 6 cases, but in the health department, just recorded the 5 cases. They're missing one case. I don't know about the maybe we still analyze it. It might be because unfinished or is it ongoing treatment or something we still analyzing. And who might be excluded in Indonesia, like maybe, it's my opinion, is a resident in the frontier, because the resident in the frontier is sometimes they far from surveillance facilities. This might be can be selecting. This might be bias if including in the one whole data. That's my answer. Thank you, Dr. Lintang. Thank you, Dr. Nadira.
Thank you so much for sharing. That's a very interesting, and I would say I learned a lot from you. So is there anyone else to share their thoughts?
Okay, I think in the chat, Crispin want to share from his country. Crispin, are you audible? Or do you want to talk in the chat? Crispin also one of our international student.
Okay.
Dr. Nadira. Crispin,
Yes. Can you hear me?
Yes. Loud and clear.
Okay. So, yeah, I wanted to report, I'm using data from my country, Malawi. So the survey, which is called Malawi National Stepwise Survey for Non-Communicable Diseases. So the data is for 2017. So basically, it reports the data for different non-communicable diseases, for example, hypertension, diabetes, and all other. So maybe just okay, so just maybe a quick snapshot. Like one of the key findings from this data was that 65.2% of the people who participated were not aware of their blood blood hypertension, blood pressure measurement, 65.2.
Okay.
And then 94.9 of the people who had hypertension at that time of diagnosis, they did not know that they had hypertension. So that's 94.9. So one of the barriers, because one of the barriers which we can take from this case is we can talk of underreporting, because 94.9% might not be the true percentage, because probably there is underreporting, because this data is taken from the health centers, hospitals, and other, and even the private sectors. So from this data, we can see that 94.9% might be that, or even maybe I should start with the 65.2. 65.2 might be because of maybe lack of integration from the community screening programs which are done. So the survey captured a different data, but maybe because of lack of reporting from different outreach clinics which are done by, for example, the health centers, that data was not captured. And the other challenge, which is contributing to this, is the limited electronic systems. So most of these cases, most of these 94.9 cases were people from rural areas. So we can see that these people probably because of lack of reporting or case detection issues, lack of integration of the systems into the main reporting system, because this one is the national. So this percentage can point to a fact that probably the health centers in the rural areas did not report the data. That's why the nation is reflecting maybe a high percentage. Yes. So on the fragmentation, there is also a problem of private sector, as Dane said. In my country, people live more of the private because mostly in the public hospitals we don't have medications, so the medications are found in the public. So these high percentages might not be the true reflection of the situation on the ground.
Yeah.
It might be other factors coming into play. So who might be excluded? We can talk of probably some of the people who have non-communicable diseases, but they did not visit the nearest. We can talk about even the people living in the rural areas where geographical barrier is also playing a role.
That's true.
So in terms of the bias, the selection bias is going to come in, because these percentages probably they are not taking into consideration these people who did not visit the hospitals in the rural areas. So there is also selection bias. One improvement is integration of the electronic surveillance system in Malawi. I think this one can improve these high unrealistic high percentages like 94.9. Because this one's I don't think is what is on the ground, but it's because probably of the weak reporting into this system. So this system, different hospitals, they are the ones who report directly into this system. Yeah, so that's what I also wanted to contribute from my country. Thank you.
Thank you so much, Crispin. Okay, so that's a very good sharing. And thank you for to Charisma for sharing. Dr. Lintang, if I may ask you, could you compile the rest of the students' thoughts and share it with me? So I would love to read everyone's thoughts. But don't afraid. Next week we're going. All of you will talk more than me. because next week we're going to do, I mean, like a bit more presentation. Let's see how it goes, and I will pass the information to Dr. Lintang, and Dr. Lintang will let all of you know. Okay, so I think there's like another 3 slides to go. So as a good public health practitioner or in any field, I would say when we identify problems, we also need to come up with solutions. So these are 3 solutions that have been done, and I would say this is where been done in I would say a Western or more like high income countries. So again, solutions, you need to be specific to your country. So as every countries has their own specialties, their own differences, and their own uniqueness and challenges. So you need to come up with your own solution. But it doesn't mean that we cannot use what have been established. So the first one is the Sentinel surveillance approach. So it's focusing on representative group of high quality Sentinel sites rather than trying to track every case nationwide. So the benefit here is allows for the careful selection of units to ensure data validity and is a cost-effective way to track time trends. So for example, here the Swiss Sentinel Surveillance Network has used general practitioners since 1989 to validly monitor asthma incidents. So the next solution is the STEPS framework. So the WHO stepwise approach use physical and biochemical measurement, blood test, weight to verify reported data. For example, here, a STEP survey in Addis Ababa revealed an obesity rate of 38% of women, which was more than double the rate reported by traditional health surveys. And this demonstrates why biochemical measurements are necessary to overcome self-reporting bias. And that's just 2 solutions, and I think okay, so another 2. So now how we can enhance data validity via EMRS. So what is EMRS? EMRS is a electronic medical record system across a network, increases the quantity and timeliness of data, which is, I think this is where Chris Pin, if I'm not I pronounce your name correctly, trying to improve for his country. So automated software can scan medical notes for specific public health events, reducing the burdens on clinicians. So I think the usage of AI nowadays is very, I would say, handy, but also at the same time, we need to be careful with AI too. But we can use AI to reduce the burden of clinicians by maybe have like scan and can detect medical doctors' notes and just having straight away to reporting or surveillance. And then, for example, the ESP surveillance platform in the US automatically communicates findings from EMR directly to public health agency. So again, I would say this we can the United States can do this because they have financial resources, which is more than what our countries have. So again, we need to think about what can our countries do within their capacities, but also at the same time, we cannot use that I'm not saying excuses, but we cannot use that sentence to justify we're not doing that. Okay, so you need to balance that out. So future directions is we need a centralized international mechanism, potentially a treaty to mediate data sharing and ensure reciprocity. And I would say for certain disease, WHO has the global database, but again, there's a lack of country included, and also sometimes even the country itself, they don't want to share the data that they don't want to share. Okay, so successful surveillance must link facility-based data with population-based surveys and administrative records via unique patient identifiers. And I think this is what Karisma discussed or shared with us just now, is how can we link, or like how Malaysia have the IC identification card where everything's there, but I'm not really sure if like our health records also there. So that's where we can try to pursue if it's feasible to do. And final thoughts for me is that harnessing the potential of data is the only way to achieve 21st century population health. So I think that's all from me. And I would like to open the floor for any questions before we end the class and meet next week. So I'll pass to Dr. Lintang. Thank you so much.
Thank you. Sorry for the leak sound. Okay. Thank you, Dr. Nadira. It's a very amazing, insightful presentation, especially regarding the practical barriers that often affect surveillance system in the real world. So it's not only technically, but also operationally and institutionally. I think many of the issues discussed today are highly relatable to our own setting or Malaysian setting and experience. Okay, now we will open the floor for discussion. So all students, please feel free to ask questions or just sharing your thoughts or even reflect on your own experience related to that.
That's true.
So don't worry about asking simple questions. Sometimes this question lead to the best discussion. So you can raise your hand or type your question in the text box. Anyone? Dr. Bagaskara? Saya main tembak-tembak aja nih. Oke,
Insyaallah
Pak
clear, Bu.
Karis. Ya, oke, Pak Karis. Silakan, Pak.
I want to ask you some question about the surveillance data, collecting data. Like I said before, about the collecting data, as we know, Malaysian has integrated system. Like I don't know, it's already applied to health system or not. But in Malaysia, as we know, has a MyCard for the integrated something data for the like a gas station or something else. But if it can do in Indonesia, I need your suggestion. How we supposed to do as epidemiologists to meyakinkan ya, Bu?
Convince.
To convince our government it's important and it's make not misusing the data. So I want to ask about how we convince and how we ensure the people to socialize about the ethic and confidentiality data. That's my question. Terima kasih.
Thank you so much for your question. Okay, I will say that's a very technical question. How to convince governments, but again, I think it starts with how you are collecting data. And I'm not sure about Indonesian governments, but Malaysian governments, they really love numbers. So, and they really loves so in a way, I would suggest that do we can have like national database first that have all the informations? Do Indonesia have that? And then if you already have that and just trying to integrate to your identification card like Malaysian, I would say it's another way is to use case studies. For example, use Malaysia or any other countries on how we are successfully being integrating all the informations there. But I would like to emphasize what you emphasize, Charisma, about the confidentiality and ethicality, because there's a few times that I'm not sure whether this is true or not, but there's like a sudden panic where everyone's like, oh, there's a leak of data. So that's another thing that you need to consider when you having a whole system in one identification card, because people can just take your data. And I think this is where you need to don't work in silo. And this is I also see in Malaysia, where like each department, or for example, people from public health tend to work in public health too. So this is where you need to talk with someone's in IT, someone's in technology on how we can do this. So you don't have to do it alone. You need to bring everyone's in, because this is involving not just from your specialist or your expertise. You need to bring in from IT, the technology part. Is that like I'm not helping you with like very solid suggestions, but I think the first thing is you need to find or you need to develop a group from different field, not just from public health. So I think with this technology stuff, you need someone from technology IT's people in order to do that. Does that make sense?
Yeah. Actually, we have a lot of national data in several department in Indonesia. Every single ministry have a lot data, national data, but try to integrating one by one in the one system, like MyKad in Malaysia. Is I think they still have some ego. That ego that might be that's my ego, and maybe it's my opinion. It's I don't know about the allocation of budgeting.
Yeah.
It might be a little bit harder to make our government to sit together and discuss this thing. It's really good for our surveillance system.
That's true.
That's my opinion, because and the question is the question in my head is why Malaysian can, but why Malaysian can do that?
Yeah.
Why Indonesian can do that? Because the technology is very similar.
Yeah.
It's very similar.
true.
It's even we can exclude the ego. We can exclude the but the technology is very simple. We use biometric system. And then we compile the data by a big data country. It's just like integrated in a one platform.
Yes.
One platform. It's very simple actually, but I don't know
Yeah,
why
that's true.
That's very
That's
difficult.
true.
Very difficult to do like that. For me, until right now, the reason is still allocation of budgeting. It's
That's true. I mean,
Lintang mau nambahin?
yeah.
Lagi rame ini soalnya ruangannya nih, udah mau makan-makan ya, sedih susah.
What?
Sorry,
Yeah,
Nadira.
okay, baik.
Terus lagi.
Yeah, but we have a potluck also, Nadira, so it's a little bit noisy, so
Yeah.
thank you.
Actually, saya nak cuba try to speak Malaysia, but I didn't confidence about the user Malaysian.
Sorry.
Because saya nak tinggal di Malaysia kan saya junior high school, so that's why I little bit can speak Malay.
Oh, okay. No worries. I always watch Indonesian sinetron. I keep sharing with Mr. Lintang. I watch, bawang putih, bawang merah. I mean, like, Malaysian love Indonesian sinetron. So don't worry. I'll understand that. So I think, when you mention, okay, this is, I hope it stays here. What we have learned stays here. So I would say this is another thing when involving government. They have their own interests and their own agenda, I would say. And as someone who like from public health, I think the only things that we can do is to keep pushing for that. But also at the same time, you need to know when is the right time to push for that. So technically be strategic in where you can try to push. And again, politics, governments is tricky to really have like one solutions. So maybe you need 10 solutions and then throw it different times. So that's, I think, the suggestions, because again, they have their own thoughts, their own egos, and I don't know like how, but I will say is that don't give up, but also at the same time, you need to know when you need to rest for a while. And this is not just one your own mission. You need to be like, you need to create this mission as like with a lot of people, so that you're not burn out and give up. So yeah, it is a very good, I would say, good strategy, good strategies or good things to do, but it takes times. So don't give up. That's the only thing that I can say. Don't give up. Okay. So there's two questions from Crispin. I'll try my best to answer your question. Okay. So let me answer the second question. As a gender specialist, how do you look at impact of key population discrimination or stigma on public health issues? Okay. So if I can give you an example, so at the moment I'm doing also about sexual health research. So again, and specifically if in more details, it's about family planning. So when we're talking about family planning, means that we need to we talk about birth control, right? So the stigma with family planning here in Malaysia is that from Muslim communities, it is taboo to talk about your periods, taking family planning methods, because technically you sort of like, oh, you not accepting the blessing from the God. So that's their perception, right? So in a way from that, how do I look at the impact is to understand first what are the stigma here, and try so this is where I think qualitative research is much more suitable in this area, because you need to talk with these people in order to get the information. So in a way, as a gender specialist, we tend to look at the lived experience. I'm not saying we cannot do that using survey, because I'm also a quant person. So survey, you can use survey, but there's an element from like when you use survey that cannot be captured. So you need to use interview or focus group discussions, which is, or in a way that you need to go into the communities and talk with them. So as a public health specialist, I'm not in medical settings. So I have no idea about anatomy or anything. So I'm more from communities. So I'm looking at the socio-economic factors. So my work more with communities, where I go to the communities and I talk with them. So sometimes this is where the stigma comes in on public health issues. So when I start involved with family planning research, one thing is I talk with the communities, and another one is just to share with all of you, I managed to work with Ministry of Health from Laos when we're talking about family planning. So this is where like we're having, I think, 3 days workshops with them. So this is where we provided evidence, or this is what the community said. So and then can have like not mediation, but just like discussion with the Ministry of Health on how we can pursue this and how can they help or how can they do as a government to tackle these family planning issues. So that's how I, as a gender specialist, is to use whatever that I can, but most important things to do is to talk with the communities to understand the discrimination or stigma on public health issues. And the first question is, what activities are you doing in Malaysia to integrate key population? For example, female sex workers in public health issue, for example, HIV. Okay, how do you make them feel comfortable to open up on their? Okay, so this is where I will because I also teach gender studies in Malaysia, so I always say that this is a safe space where all the students can share their thoughts and just stay there. Okay, so with this I would say, for example, the sex workers, one thing you need to do is you need to build rapport with them. So in a way that you cannot go there just once and to collect data, they won't open up to you. So in a way, you need to be in the community, but still as an outsider in the community, but at least you are there to understand or to I would say to sort of like have the experience on how they lived. And another thing that this is not the sex workers research, but when I did research on gender-based violence, where I talked with NGOs that help the survivors of gender-based violence, one of the things that they felt reluctant to involve with this matter or to involve with like national or international organizations is that it's just only one-off. So they treat all the NGOs as a data mining. So they are not having this continuous relationship. So again, with particularly vulnerable groups in your countries, you need to have continuous relationships and you need to treat them not as data mining. So you need to be there to be to understand their situations and try your best to keep or to maintain the relationships. So I hope okay, the last one, come again on strategies which us as epidemiologists can use to make sure that we are taking into consideration the gender. Okay, so this is a very good question. So first thing first, I would like to I think I would say the first step is you need to go beyond sex. You need to go beyond this is also what I see in Malaysia when they have the survey questions. They will ask gender as female or male, but that's sex. So we need to differentiate between sex and gender. So gender there, you need to include all the genders that you can, and then ask them to choose what gender they have identified. So that's the first thing. The second thing is that have you heard about intersectionality? So I think this is a very good framework on looking at gender, which is intersectionality, where okay, I'll just put it here. Intersectionality framework by Kimberly Crenshaw. So this framework will help you to understand that as an individual, we are more than that. And we have a lot of other factors or other characteristics that that the policymakers need to understand in order to develop policy or programs. If I can find that, I will share you about how you can integrate intersectionality framework in public health setting. And I'll also try my best to find there's a guideline already actually between gender and health framework. which is I think I will try to find that and share it with Dr. Lintang, and hopefully Dr. Lintang will share with everyone else. So we almost reach 12. I'm going to meet you all next week. So I think if there's nothing, I'll see you next week then. Is that okay?
Okay.
Lintang, don't go.
Okay.
Thank you so much. Okay. Okay.
So sorry, I'm in the
Okay.
middle in
Yeah.
the middle of meeting also. Okay,
Okay.
all right, everyone. I think we had a very meaningful discussion today. On behalf of the Master of Epidemiology Program, Universitas Diponegoro, I would like to sincerely thank Dr. Nadira for the excellent session and for sharing such valuable insight with us. And thank you as well as to all students for your participation and engagement throughout the session.
Yep.
You guys rock. Okay. Hopefully today's discussion not only improve our understanding of surveillance system, but also encourage us to think more critically about the real challenges behind public health data and decision making. Thank you once again, everyone, and we will see Dr. Nadira in the next meeting.
Yes.
Please stay safe, stay healthy, and have a wonderful day ahead.
Yep.
Thank you.
Bye everyone.
Thank you,
Oke,
Dok.
thank you Nadira. Terima
Bye.
kasih ya semua.
Thank you,
Terima
Dr. Nadira.
kasih. Nanti ini ya. Ya, thank you ya. Izin live ya Siva. Aku ada rapat lagi soalnya. Thank you.
Terima kasih banyak.
Guys,
Udah kan?
see you. Don't forget for the class